Hello. Hello. Hey, can you hear me? Yes. People in Zoom as well. We're having some issues here with the camera. We're going to try to fix that problem in a moment. I know that you all can hear us pretty well, those in Zoom, and we're seeing our slide deck. So we will start on time. Thank you so much for everybody to be here in person or Zoom. I think combined we have almost 40 people, 45, which I think makes us really happy. This is the first of the 3 implementation science centers that we will be having in 2024. This is, and we cannot start, with a better speaker in this year. So I want to introduce our speaker, Dr. Shari Rogal from the University of Pittsburgh. She is a gastroenterologist, transplant, hepatologist, and implementation scientist. She co-directs the Dissemination and Implementation Science Core in the VA Center for Health Equity Research and Promotion. She also works at the University of Pittsburgh, where she co-leads the CTSI Dissemination and Implementation Science Core. Her research focuses on developing empirical and pragmatic approaches to identifying implementation strategies that improve healthcare and reduce disparities in health outcomes. And yesterday, when I was talking with her, she was telling us the 2 new grants that she's going to be receiving, one from CTSI to establish a PRC, Prevention Research Center at Pitt, and another one, that one is focusing on diabetes management, and another one funded through PCORI, focused on liver cancer screening, right? So she's going to be really busy in this, not only with her implementation science work, but at the same time also leading some other research. So I want to have plenty of time to her for her workshop. The first hour will be didactic lecture, then we'll have a 10-15 minute Q&A, and then we have a couple of exercises that hopefully we can do both in person and via Zoom. So please help me welcoming Dr. Shari Rogal. She's so good that she's going to be doing 2 talks today. One this one, and then another one later in the course. So.
Yeah, and I can't stand behind the podium. I also can't stand still. So if I get too far away and you can't hear me, just tell me. But it's nice to meet everybody. Thank you for having me. I need to get rid of this picture. ASAP. It doesn't want, oh, what do I do? Just click on anywhere on the PowerPoint. Oh, yes. Okay. So today we're going to be talking about some practical applications of D&I in research and practice. So my nerdy research stuff focuses on empirically linking barriers to strategies. But my fun side hustle, unpaid job is to try to figure out ways to teach this stuff to people who are doing implementation work that maybe haven't heard too much about it before. So I came to implementation science sort of later in my career after fellowships and all those things, and have been doing some health services research and realized that this was really my passion. But I also realized that it was a different language that didn't have to be so complicated as it was. So just as I think, does everyone in this room do implementation research? Or no? How many people do implementation research? Okay, and how many people do implementation practice? Okay, cool. So I think some of this will be review, but I want to hear a lot about your work. I like things to be interactive, so just holler if you have something to add or something to say. So as most people know, there's this like chasm or gap between research and practice, such that it takes about 17 years for something that's evidence-based to percolate into everyday practice. And I used to show pictures of penicillin and smallpox and try to convince people that this was important, but now I just put up this picture of the COVID vaccine and everyone understands why, even though we have an innovation, sometimes it's not adopted or not implemented well. This is not a new discipline. It's sort of a collection of methods and theories from across different disciplines. This is Everett Rogers, who developed the theory of innovations in the 1950s after seeing that GMOs in farming weren't being adopted, and he was wondering why that was. And so It's kind of interesting historically. And so I think this really got more popular as all these reports started coming out, in the 90s and early 2000s about just the quality gaps that we were seeing and all the errors, the medical errors that we were seeing. Implementation science emerged to be the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, which is a little bit circular, but if you met Brian Mittman, he's a great guy, but very, very cerebral. Essentially what it is the difference. In an ideal world, we would take, clinical expertise. We would take into account patients' values and preferences and the best of research evidence, and that would be the kind of care that people get. But anyone who's been in the hospital recently or had a loved one who's been sick knows that this is not actually what happens in reality. And so T3 and T4 research are focused on the translation of research to practice and communities, and that's really where implementation science fits. So the usual sort of study, and what I was doing before I got into implementation research, is that we figure out what the impacts of a practice or an intervention, what that does to health or healthcare or health outcomes. And that's sort of the usual association. So you look at, okay, if we do cancer screening, does that improve mortality? Something like that. But in between, around all of that is your context and sort of the contextual barriers, facilitators, determinants. And in the middle of all of that are these sort of implementation strategies, or sort of the how of how you get to how you do your implementation. So what are the sort of methods or techniques that you use to enhance adoption, implementation, and sustainment? And then there are implementation outcomes and service outcomes that we often fail to measure. And so implementation science sort of emerged to look at that middle yucky messiness in the middle. And if you saw the back of my van, you would understand why I'm totally into this messiness. And I think a lot of times people get confused about D&I research versus clinical research. I think this crowd probably has a good sense of the difference. But really, again, D&I really looks at that messy in between, as opposed to trying to control for or tolerating contextual covariates. And so we're really trying to figure out how people use the thing, and we'll get more into this later, as opposed to does the thing, the evidence-based intervention or practice, work? In D&I, we really love context, interdisciplinary partnerships, and teams are sort of at the center, whereas in clinical research, it's really focused on a research team, and then individuals and structures in the clinic sort of passively support the innovation. So people sort of dread working with sometimes challenging centers if they're doing a cluster randomized trial with the patients, whereas in D&I, we want to measure the difficulty. And people get asked a lot about QI versus implementation research, and then dissemination research versus implementation research. So quality improvement really begins with a specific problem and a specific setting, rather than necessarily the evidence-based practice. And it's focused on that setting and not on generalizable knowledge. There's a little bit of a regulatory issue in here, whereas sometimes you can get a lot of I just finished a giant VA step wedge trial, and it was considered QI by the VA because it was so partnered and aligned with, but I think traditionally when people think of QI work, they're thinking of one setting, not generalizable knowledge. Dissemination research is focused on how do we spread information using communication and education strategies. A lot of implementation researchers consider dissemination to be one part of implementation, or one type of implementation strategy. But people who are really focused on dissemination don't always agree with that. So I'd like to say really controversial things. So I'm never going to say this. Okay. So what I'm going to do today is go through a step-by-step guide to dissemination and implementation. And this is the way that we actually teach our students to do this. This is also how I work. It's an adaptation of this program called Getting to Outcomes, which is meant to help community partners select evidence-based interventions to apply, implement, and then evaluate. We adapted this to Getting to Implementation, which is a way for clinical settings to select implementation strategies that actually empirically match the barriers that they're experiencing to do more precision implementation, and then adapted it again into this teaching model. But we're going to talk a lot about the updated CFR, since that's something that I'm hoping to shepherd and teach about. We're going to talk about sort of how you know if you have an implementation problem. If people are like, this is, so far, is this stuff everybody knows? Has anyone learned anything new? All right, good, okay. So hopefully, so this is GTI Teach. This is the 7 steps to figuring out how to do an implementation, project. And this is what we recommend to people who are new. So I think to those of you who are more experienced in implementation, I would just urge you that you can be those experts on other people's grants. Like you can be the co-investigators if you're not the implementation experts. And you can walk people through this. It's not that hard. It's definitely not rocket science. Otherwise I couldn't do it. Okay. So first we're going to talk about, and this is all on your handouts too. So first defining the implementation problem, then conceptualizing it. And we'll talk about CFR in the conceptualizing part. Then prioritizing the implementation barriers and facilitators, selecting strategies or implementation strategies, testing them, evaluating them, and sustaining them. So these are sort of the key tasks in each step. So when we think about defining the problem, the most important thing is to think about, is there an evidence-based practice and is there a gap? So, and making sure that you have an implementation question. So a lot of times when I get consultations through the CTSI, people ask me questions that are really efficacy or effectiveness questions. Does the thing work? And so we'll talk through this a little bit. So the way that I think about this is Jeff Kern. Have you guys read this like 1-page article in implementation science? Yeah. So he's like a great guy and he's super funny. And for years he would teach implementation science this very simple way where he would say, okay, so you're talking about the thing, that's the thing from the Addams family. But the thing is the evidence-based practice or intervention. If you're talking about how well the thing works, that's an effectiveness question. If you're asking how do you get people to use this thing that you know works, that's an implementation question. If you have an implementation strategy is an intervention to get people to use the thing more, but we'll get into that. But anyway, I just think it's really, I always ask people to start by really delimiting their evidence-based intervention practice. It can be something that's already out there that's just not being done well, like cancer screening. And it can be a little bit confusing because if you think about a digital health intervention, is that your thing? Is that an implementation strategy to get somebody to do an evidence-based practice? So you can define things at different levels and that's fine, but you just need to define your thing, whatever it is. And it should be evidence-based, please. Okay, so, sorry, the animation isn't working here. We're supposed to just pop up one at a time. Okay, so we're gonna do a pop quiz. Is this a D&I problem or is this not a D&I? Is this like an effectiveness or efficacy research problem? Okay, so this requires audience participation and public humiliation, potentially. So just prepare yourselves. No, I'm just kidding. It's a safe space. I know, William, you're recording, but we're not posting this, right?
We're going to be posting in our CTSI YouTube channel, but just in case I'm ready for public
okay.
I'm okay with that.
Okay, good. Good. I already am publicly humiliated on YouTube in many, many ways. Okay, so here's the question. All right, so maybe raise your left hands if you think this is an implementation problem. Raise your right hands if it's an effectiveness or efficacy question. Okay, and we'll see if I can tell left from right. Okay, so does CBT improve quality of life? All right, cool. Okay, good, everyone got that right. Do colonoscopies or stool tests improve cancer detection more in the real world? Some confusion. Okay, so who wants to talk about this? Does anyone want to talk about this or do you want me to talk more?
I see the CRC test as the EBI.
Yeah.
You can improve the uptake the more into the real world by doing other things like practice facilitation or telemetry training, other things. So what I'm seeing CRC test here I see the EBI only.
Yeah, this is a comparative effectiveness trial. And so it's pragmatic and whatever, but it's still effectiveness. This is not an implementation trial. The fundamental question is asking which EPP works better. Does caregiver support improve end-of-life care for patients? All right, good. Does provider education increase knowledge about PrEP? Yeah, so usually people get this wrong. Like, so there's no shame in the room. So I gave a very similar talk to like leadership in CMS, and they got this one completely wrong for the most part. So you're doing a provider-facing intervention, but you're trying to improve something about what the provider knows. If you were asking, is provider education an implementation strategy that improves the rate of colon cancer screening for patients, that would be an implementation question. But as it is, this is, the effectiveness is an education intervention for provider education knowledge. Okay, shoot, I just gave away the next one. It's education. Okay, perfect. All right, what contextual barriers must be addressed to improve cancer screening? You guys are killing it, William. Okay, what policies need to be in place?
You should probably let the people on Zoom know what the answers are.
Oh, well, they didn't bother to show up, so I'm just kidding wherever you are. I'm totally kidding. So implementation, the group in the room nailed it. I'm not sure what happened on Zoom. No one knows. They're probably drinking coffee and wearing peaches. That's what I would be doing if I were at Zoom. Okay, what policies need to be in place for providers to prescribe buprenorphine to patients with opioid use disorder? Yep, implementation. Woo! All right, what supports do teachers need to engage kids in an evidence-based drug prevention program? Awesome. Which program should the military use to prevent sexual assault? Yes. Yeah, effectiveness. Which one's the most effective? Yeah, exactly. If you wanted to help them implement, which my partner in crime, Matt Chimman, has done this project, that is an implementation question, and it is a challenging one. Okay, how closely do we need to follow the protocol of an intervention for it to work? All right, everyone agrees it's an implementation question. And how do we get hospitals to sustain efforts to address burnout among staff? Implementation, yeah, sustaining question. And what can help prevent staff burnout? Oh my gosh, okay, good. All right, so let's go on to conceptualizing the problem. Do people in the room have a favorite framework or model or theory that they tend to use in their research? People on Zoom can contribute too, but I won't know if you are. Well, maybe if they don't, it'll pop up in the chat. You can tell me. Okay. Does anyone have something that they like to use that they're familiar with? Shout it out. Okay, good. No, I'm just, gave this CFER workshop, and I was like, but I'm friends with the EPIS people, we're friends with the REAM people, everyone's great. It's not really like, there's no like cage match to determine the best framework, unfortunately, because I would win, because I have a black belt in karate. But that's just a side note, and to scare everyone in the room. No, I'm just kidding. Okay, so are people familiar with theories, frameworks, models in the room? Okay, so we know that there are sort of 3 types in general of different frameworks, FTMs in implementation science. There are process models that explain sort of how to go about doing something. I would say that actually the 7 steps we're going through today is a process model. There are explanatory or determinant frameworks, CFER's one, and then evaluation frameworks. And so, if you guys haven't read this Nielsen paper, it's a really good explanation of like sort of the different types of frameworks, theories, models, and I like it. It divides them into describing the process, understanding implementation, and then evaluating implementation, and gives some nice examples. Oh, You need to get that, didn't want to get that. You guys can have the slides. Okay, so process models, again, KTA, knowledge to action is probably the most famous, but of course I put our GTI teach model here. Okay, determinant framework. So EPIS is here. EPIS is really considered historically to be a process model because it talks about these different stages of implementation and then what you would want to do in each of those stages. But it has more recently developed a determinants flavor. Similarly, CFR has always been considered sort of a determinants framework, but it also has a process flavor that got built out in the update. And so we'll talk about this a bit more. And then in terms of evaluation frameworks, most people use REAIM. REAIM has built in some determinants by adding PRISM into their model. So if you talk to the REAIM people, they want you to say REAIM and mean REAIM with PRISM included. So I think all of these things are sort of converging on this, you know, they all want to be one framework to rule them all, but you know, it's fine. I tell new people just pick something and get good at it, and then the rest will come because it's challenging. This is a really nice website that I know that William said he's recommended to people. Rachel Tabak sort of put together this website where you can think about models and frameworks, and you can pick one that might be good for you depending on how broad or specific you want it to be, depending on how dissemination or implementation focused you want it to be. And this is just a screenshot from that website. I think you can also just pick something. Like CFR, I would probably say CFR, REAIM, EPIS, or sort of the REAIM with PRISM are the most common sort of three. But what we tell our students is you don't have to understand any of this. Basically, when you're conceptualizing the problem, you're making a hypothesis about what is the implementation problem at work here. What do you think are the contributors to that problem? And then you can map that onto a determinant framework or whatever you want to do. But really, when you're new to this, just think about, you know, people have a lot of experience in life, a lot of thoughts, and, you know, just getting people together and thinking about what the problems are. And then you can map them later. So I'm going to talk a little bit now about CFR 2.0 because I think it's been confusing. Has anyone tried to use the updated CFR? Okay, 2 people. Okay, so this is kind of new. Okay, so I'll talk about this. So Laura Schroeder is, you know, really, this is her, I call it her baby. So she developed CFR along with a team of people who I've been privileged to be able to work with for a while now. And so you know, I'm talking about this, but this is really, you know, her work. So we talked about that already. So CFR basically is a meta-theoretical conceptual framework. It's based on a bunch of theories, models, and frameworks, put them all together to try to explain factors that can either help implementation or hurt implementation. And so it stands for the Consolidated Framework for Implementation Research. And it's been extremely influential. It's actually over 10,000 citations, the top 10 cited paper every year in implementation science, which is the leading D&I journal. But now that I've kind of seen under the hood of the CFR industry or collaborative or whatever, there is constant emailing and back and forth, and people have a lot of thoughts about this. And so Laura, in anticipation of retiring, wanted to sort of update CFR 10 years later. So this is the, basically did a systematic review of all of the papers that made recommendations about CFR, then went to people who had used CFR and had them do surveys about sort of the different parts of the framework. And then, you know, most of the items received very favorable ratings, but some of them didn't in terms of applicability and usability. So CFR 2.0, or updated CFR, had 3 big conceptual changes. The first is that it really, people always were coming and saying, CFR is not, are you trying to measure what's actually going on or people's perceptions of what's going on? It's all going to be perceptions. You want to, when you're applying CFR, you're trying to get the perceptions of people who are in a position of power and influence to change or influence implementation. And so it's interesting because I think one of the big flaws that, or one of the big errors that people make when they're applying CFR is They want to talk to patients. Now, I am a clinician. I am all about patient-centered work, and I always have patients on my teams, on my boards, people with lived experience. That's very important. But CEPA wasn't designed to actually get patient opinions because, unfortunately, patients don't typically influence what goes on in your clinic, you know, and they don't maybe understand what is the leadership structure and what's actually getting in the way of a provider's behavior. So depending on the context, you know, will depend who you want to talk to, but you definitely want to think about who actually is involved in what is the behavior that you want to change. So is it a clinician prescribing a medicine or offering a cancer screening test? Who are the people that sort of influence that clinician? And the patients do have a role in that, but the questions you would ask patients would be different than the questions you would ask, you know, a policymaker or a clinician. The other thing that CEPA 2.0 really wanted to clarify was that it's really important to define and delineate the boundaries around your domains, and we'll talk about that in a second. And also took all of the people who were scattered, you know, if people knew old CEPA, like, right, the patients were in the outer setting, the leadership was in the inner setting, and, you know, policymakers were in an outer setting, and it just put everybody into a characteristics of individuals domain. So because that was a point of confusion previously. So here are the domains, and I think on your worksheet we'll work through this, but essentially these are the big five. And most frameworks, I think, in implementation really think about this. So the innovation, so CEPA 2.0 also changed the name from intervention to innovation, but we'll talk about this in a second. So what is the thing being implemented? And what you're asking about are really perceptions about its properties. So you could have the most evidence-based intervention or innovation, but if people don't believe that it's evidence-based, they're not going to do it. Then we talk about individuals. So who are the individuals most likely to influence or have authority over implementation? Who's delivering the innovation? And so we can talk about that. You know, in individuals, you also want to ask who's the recipient. What are the characteristics of the recipient or the patient or, you know, the end user, depending on what you're talking about. But the people you're going to talk to are different. The people you're going to talk to are the individuals who have influence or authority over implementation. The inner setting is where you're trying to do the thing. So, and delineating between the inner and outer setting, I sort of think about it as what is my unit of randomization. So if I am going to randomize at the clinician level, then maybe it's that patient's or that provider's clinic, but more generally it's at the clinic or hospital level or at the, and there can be multiple layers. So you could be at the school or the classroom level. I think most people here are not in education. Is anyone in education? Research? Okay, cool. So I'll keep doing them, like education examples. Okay, then the outer setting is wherever your inner setting ends and the other stuff around it begins. So it's a little bit circular, but definitely define the limits of your inner setting. And then the process is when you're asking about the determinants of the process, to what extent do the people in the roles category, the individuals category, do the things they need to do for sustained implementation? We'll get into that. So the process domain was extremely confusing to people in original CEPA, so they tried to build it out and clarify what it was and what it was not in the updated CEPA. So here's an example from some research that I had done around hepatitis C treatment. So we got these new medications around 2014 that went from being, you know, 20% curative to over 95% curative with a pill instead of shots and with no side effects. So we got this new innovation. We were asked to sort of think about how to get this innovation diffused to everyone in the VA, all the veterans with Hep C. So we talked to leaders and clinicians and payers and patients. Our inner setting, so we defined this by VA hospitals. That was our unit of assessment. And then the outer setting was sort of the VA system as a whole and outside of the VA and sort of, you know, federal policy and things like that. And an example in the process was sort of how did we plan for implementation? What were the strategies that sites were using? How did they work? How did they not work? How did it, you know, how did the implementation go? Okay, so I think that if we just got to there with some of the newer students that we have in our class, we'd be happy. But this group is a little more further along. So we're going to talk a little bit about some of the changes to the different domains and how we might think about them. So the innovation domain, I guess the most important thing I would say about this is that it's really important to identify the type of innovation that you have and the components and what components are sort of core and necessary versus adaptable. And the reason why this is important is because that's how you know what an intervention is versus your implementation strategy. So we just did a systematic review that was like co-funded by PCORI, looking at the evidence around different implementation strategies. And one of the things that we found when we reviewed, thousands of papers and stuff, was that people were really not doing a good job of sort of saying, what are the core components of the innovation? What are you considering to be implementation strategies? Without that, it's really hard to measure the impact of the innovation versus the implementation strategy on outcomes and intermediate outcomes. So if that's a really big point, I think. And so, yeah.
Is that also how it's delivered? Like, do you do it online or do you do it in person in a classroom setting? Is that what you're getting at?
I think that's a really good point, exactly. So you get to define that. And so you could say, so we did this workshop with digital health people and we've really talked a lot about this. So, but you really get to say, is the intervention CBT, like cognitive behavioral therapy, is that your evidence-based intervention? And then you're trying different strategies for delivering it,
So on here, when you say different strategies, is it a type or a component or is it somewhere else? That delivery piece, is it a component? So CBT is the thing, right?
Yeah, so you could say that my innovation is online CBT. Here's all the evidence that works. To get people to use that online CBT, I'm going to apply a strategy. I'm going to use, facilitation. I'm going to use whatever strategies you pick. Or you can say, I have CBT and varying the delivery method or we're either going to do it in the clinic or we're going to expand sort of, change where we do the delivery. And that's one of my strategies that I'm testing. So it can be confusing. Education is one of those things that's really confusing. Is education a strategy? Is it part of the intervention for clinicians? Is it, you know what I mean? So you really have to be really clear. What is the evidence-based practice? What are the components that are core? What are adaptable? Because adaptation or making your EBP adaptable is an implementation strategy in the ERIC taxonomy. And so it can get really confusing. It does not have to be. So I would say, that's why I literally make people who are doing a consult write out EBP equals digital CBT, or CBT. And then you write your paragraph about why it's evidence-based or not and what you're testing. So, but I think at this point, I would say, it just depends on what you're testing. If you're testing the efficacy of digital versus in-person CBT for improving healthcare, that's a comparative effectiveness trial, and that's part of your, you're varying the type of intervention. But, there are cases in which your delivery platform or where you're delivering the innovation can be considered part of your strategy, if that makes sense. Does anyone have anything they want to add to that? Because it's sort of a...
Let me come here a moment just to take the microphone.
Yeah.
Come here. There's a big discussion about that exactly right now in the field. What people are trying to come, especially Dr. Bowman from Washington University in St. Louis, is this concept about form versus function, right? And form is in-person versus digital, right? But if you change the form, but the function does not change, it's not an implementation strategy change per se. Because what matters when you change the form is that by changing the form, there's an improvement in the function of that intervention. If by changing the form does not impact the function of the potential intervention, it's not a different strategy. That's what people are conceiving that right now. But in most of my studies, when I try to understand in-person versus digital actually my main trial right now using Project Echo is not considering that into account. I'm just saying, if I'm able to deliver my evidence-based intervention to Project Echo, it's a different form of delivery. That's my strategy, right? But the question right now from the field, as it's getting more sophisticated, is that it doesn't matter if you change the form, if the form change the function or impact the function. But I think we're in baby steps in terms of verifying that at this point.
And I think also the form versus function is also really applied also when we get to strategies too.
Yeah.
So, but I think it sort of depends on the research question, how I would say. So we can talk more about it for sure. But it's a great question. The other thing about innovation, and a question we get asked a lot is, does the innovation need to be something new? It doesn't. It can be, so a lot of times, most of what I'm doing is trying to improve something that's already in place, and I'm trying to get it improved. Sometimes we're talking about something that's novel, and sometimes we're talking about something that we're actually trying to de-implement. So it doesn't have to actually be innovative. It can be a low-value healthcare practice that you're trying to de-implement. So, but it's called innovation anyway. The individual domain, again, this is how do the perceptions of individuals who have influence and or power over the outcome of implementation efforts perceive things. What are their roles? What are their characteristics? And so what I really like about this is that you kind of have to think through who are all the people. And a lot of times I'm some human centered design colleagues and I've done like the certificate or whatever. So we can use, partner mapping, what's also called stakeholder mapping in old parlance. To kind of think through who are all the people that touch the innovation, or journey mapping some people use. And then the characteristics really come from Susan Mickey's COM-B, which looks at how capability, motivation, and opportunity impact behavior for each of those individuals within that touch implementation, and to what extent do those things support versus hinder ultimately your implementation. So the inner setting domain was divided into persistent characteristics of your inner setting, so things that would cross any implementation effort. So when we talk about the VA, we think about these things, separately than things that are specific to implementing this given EVP. So persistent structural characteristics, the culture, the relational connections and communications of an organization, those things are sort of stable regardless of whether we're talking about cancer screening or vaccination, versus the tension for change, the compatibility, relative priority, alignment with mission, and available resources are more specific to that EVP, if that makes sense. Does anyone have any questions? Okay, sweet. And then the outer setting, some of the changes that they made were they added critical incidents. This is really a nod to COVID. Like, what are these really big disruptive environmental things that really change everything about implementation? And then, policies, laws, financing, everything that sort of influences implementation. A lot of times, actually, like if you talk to Laura about this, she'll spend a lot more time on the inner setting when she actually does the interviews, only because do you have power to change the outer setting? In VA, we do a lot. Like I work with the policymakers at VA central office. So we actually are looking to change policies that are hindering implementation. So in that case, I ask a lot about this. But if I'm working in sort of a healthcare system where I don't have so much power to change policies or, Medicare reimbursement or something like that, I may not ask so much. I mean, I'll ask about it, I'll take note of it, but then I focus when I'm working on changing how implementation is done on the changeable factors, and we'll get to that in a second. The implementation process is sort of the activities and strategies used to implement the innovation. And this is our new CFR figure that we made. Right now, we're putting together a user's guide that'll make it easier to apply, because as we're sort of doing the roadshow for new CFR, people are confused and they don't like it. I myself didn't like it, so yeah. Okay, so now you've got your determinants. You've thought about what your hypothesized sort of determinants of implementation are. The next step is to prioritize barriers and facilitators. So what will you actually measure? What are you considering? What are you right, you know? And so this is really about partnership. And so defining your context for implementation and who your key informants are. So if you were planning to go out and use CFER to do some interviews to understand barriers and facilitators in the real world, right now you would be thinking about, okay, who do I need to talk to? And which of these things that I think are the most important to address? So again, we'll get to this interactive activity in a second, but that's really about partnering and prioritizing. Okay, so this is the part where most of my research focuses, is how do we select implementation strategies? So strategies, again, are methods or techniques used to enhance adoption, implementation, and sustainment of an evidence-based practice or intervention. That's a quote from an old doctor. Okay, so I said that so many times that I had to memorize it. Okay, so who has used implementation strategies in their work? William, anyone else? Okay, what kinds of strategies have you guys, what are your favorites? People like generally have like little babies, like they like them the best, like a favorite niece. I don't have a favorite child in case you're listening to YouTube children.
I think for me, I think it all depends on what kind of, the selection of strategy needs to match the best attributes of your EBI, right?
Exactly.
So there's some time that if I want to be doing vaccine communication, you need to select, for example, a champion, or maybe financial incentive, or maybe is practice facilitation through Project Echo. So I think that depending what you want, what your evidence intervention is, you have to select one or the other, because not all strategies match your EBI perfectly.
Yeah, and not all match your context too.
Yeah.
So if you have a problem, if your main implementation barrier is that I do some work right now, I'm doing some work around PrEP implementation and harm reduction services in the VA. And some states, you're not allowed to provide syringe services. So that is a huge, not overcomable barrier. So no matter what I do in those states, I'm not gonna get syringe services offered because it's literally against the law. So I think in that case, I wouldn't pick any sort of strategy, versus if I had a place where it was legal, but the issue was that there was stigma or something like that, then I would pick a different kind of implementation strategy to improve syringe services, if that's what I was trying to do. So this is my passion in terms of my research interest. So in terms of defining implementation strategies, people had called this sort of this Tower of Babel, where people were talking about things using different names for the same thing, a bunch of things were called the same thing, but were actually different. And so this is one of my favorite people, Byron Powell, when he was a PhD student working with Enola Proctor, used a Delphi process to develop this ERIC taxonomy of implementation strategies. And then they used concept mapping to map them into clusters. So there's 73 implementation strategies in this taxonomy mapped into 9 clusters. And we'll talk a little bit about the different clusters and what they are, but it's just, the reason I show this is just to say there's a lot of stuff to choose from. And so I got really interested in this. We started measuring which of these 73 strategies different sites were using, which ones were associated with faster, for example, Hep C elimination, adoption, completion, different stages of it, implementation. We've measured this for 10 years across 10 different EBPs. We have all this data. So now we're doing a project where we're literally using some machine learning models to try to match which strategies match which barriers to produce better implementation outcomes in the VA, and then we're using it outside the VA also. And then trying to figure out ways to empirically prescribe implementation strategies that match barriers rather than just using common sense. Because what we found, part of the ERIC project, and we're working with the whole original ERIC team on this, so it's not like we're being rude or not, including them or criticizing them, they're part of our team. So, one of the issues is just that you find that people sort of latch onto if you have a hammer, everything looks like a nail. So certain people like certain implementation strategies, and we're really trying to say what really matches. And the ERIC team initially went through this and did a first pass of what they thought was feasible and what they thought was sort of important in terms of the strategies, so they rated them in terms of importance and effort. But what we found in the VA was that people were using strategies that they had said they didn't think were feasible or important, and they were associated with better outcomes. So how do we add some empiricism to this process of selecting strategies that'll work? So just to give you a couple examples in each of these clusters, just to kind of broaden people's minds about some of the things. Has anyone used the ERIC taxonomy, by the way? Are people pretty familiar with this? Yeah.
With most of the consultations that we do for some investigators, when they're still looking for those strategies, we share that with them. And also, when I mentioned one thing, the ERIC taxonomy is the kind of the overarching collection of these strategies, but there are some groups that have been developing some strategies more specific to context and population, like Jane Krasnowski and I are working with one of our faculty here, Deepa Sakar, and she's working on the school setting. And for the school setting, there is a ERIC equivalent called the sister.
Right.
And those are strategies tested for school settings. So I know that there are other groups that are taking ERIC in a more context-specific format.
Yes, and so I think that there is this big tension, and we run into this all the time, between generalizable sort of theories, principles in implementation versus what needs to be tailored, what needs to be specific to your, and I think about this a lot. I think it's really, really interesting. So like, what can I take from Hep C land and apply, you know, to PrEP? What can I not apply? What can I apply to de-implementation efforts like opioid safety efforts? And so that's why I'm sort of interested in measuring, sort of systematically measuring these things across lots of different kinds of efforts and measuring the context also, but we haven't gotten into education, so it's really interesting. So financial strategies would be things like getting new funding, changing fees, changing payment schemes, disincentives. If you talk to CMS, this is all they think about. So when I talked to them, I was like, hey guys, there's other stuff. I mean, they think about this too. If I talk to the IT people, like I was talking to digital health people up at Dartmouth, all they want to talk about were like these things, that change the record system, change the equipment, the physical structure, you know, this kind of infrastructure changes. And then if you talk to just a traditional health services researcher or somebody who hasn't like actually tried to do this stuff, a lot of times, I know who thinks about these things the most, efficacy researchers. They think they build the evidence and like the people will come, all you have to do is tell them and doctors will do it. Like you just have to educate them. And as a doctor who's done a lot of CME, like this is just not enough. It is a necessary but not sufficient strategy for almost everyone in home. You know, there's some early adopters or whatever, but not, but this is not enough. And that's why we need implementation research. Engaging consumers is something that is really important. We're restructuring this cluster, especially. We've done some sort of cognitive interviews and things with both providers who have answered ERIC surveys as well as the ERIC group. This is the group of the cluster of strategies that needs the most revision because it's the most overlapping and sort of redundant. But this is basically doing stuff to reach directly out to consumers. I talked to a bunch of veterans about this and they were like, where's the social media stuff? Where's all the, you know, so this needs some work and we're working on it. But just think about it, you can think about the cluster. How do you engage consumers? And this is a lot of what William, I think what you think about. Supporting clinicians, this is clinical reminders, sort of creating clinical teams. And then there's evaluative and iterative strategies and adapting and tailoring strategies. So the evaluative and iterative strategies really focus on how you like needs assessment, small tests of change. So people are familiar with Lean Six Sigma. A lot of the strategies sort of fit in here. Audit and feedback is looking at your data sort of, and then providing it back to clinicians to try to improve behavior. Adapting and tailoring to the context. This is, I think, the most confusing because of that tension between adaptability, fidelity, tailoring versus keeping things the same. And so we don't understand how this works and when this works. And this is, I think, William, where you were talking sort of about form versus function. This is an active area where people are thinking a lot about this. And moreover, people are thinking about the form versus function for each of these strategies. So I can say audit and feedback, and that's sort of like most implementation people will have an idea of what that means. It's a pretty well-defined strategy. It's a composite strategy of a couple of different things, but we'll save that for later. But that could still take a lot of different forms. Who is the person doing this strategy? How often are they doing the audit and feedback? Stuff like that. So that's where there's a group, and I know Brian Weiner and Kara Lewis and all those people are trying to think about the mechanisms of the strategies, which is really interesting, and sort of trying to stay a little bit away from that and doing more. Let's just, make it you have to do one step at a time, I think. And then providing interactive assistance. These are some high level multi-component strategies that really focus on, it's almost like coaching or working with a team to do interactive problem solving is what facilitation is. But these also, there's a whole areas of active work into each of these. So like there's people Joanne Kirshner who spent her whole life trying to understand facilitation, develop training in it, for example. Now, when it comes to selecting strategies, there are a lot of different ways to do it. This was sort of what was being talked about in 2017. These are all expert-driven or partner-driven, but they're all sort of consensus methods, opinion-based methods. And so we can talk about any one of these, but and this is implementation mapping. It's a stepwise approach to selecting and sort of specifying an implementation strategy. There's the ERIC CFR matching tool. So we have a grant to actually take our data that I was talking about before and update this tool, like make it something that's actually data driven. But what it is right now is you basically plop in the barriers that you found through CFR, and you can see what experts in implementation thought would be good strategies to address those barriers. There's a lot of flaws with the current tool. It's on the CFR website. We're not gonna not have it there, but we're gonna make it better. So if anyone's interested or has suggestions for how to make this better, please talk to me. We'd love to have more the better input. This is just what it's basically an Excel file that just outputs for each barrier what the recommended strategies are. So a lot of people use this and it's been successful in grants to say that you're going to use it, but it's actually not all that useful, partly because of the form versus function issue. It gives you a bunch of strategies and you have no idea how to apply them. Okay, so this is just more about that. This is what I do. So we measure strategy use across sites. So each row is a site, each column is a strategy, and make these heat maps of which strategies are being used, which ones aren't being used, across different implementation efforts and what the signature looks like and how they're doing on implementation. Once you pick a strategy, it's really, or a group of strategies that you're going to use, we ask that people sort of specify them. So not just naming it as one thing, and that's really important, but also providing the who, what, where, when, and why, and for the reason that William said. And when we did that review of implementation strategy effectiveness, no one was doing this. So if you just did this in your articles, this would be a huge boon for the field. Okay, so when we think about testing strategies, there are a lot of unique types of trials and implementation research that I'm not going to get into, but we could get into. So a lot of times you're randomizing at the site level or the clinic level or the school level, so you have to do cluster randomized trials. I've done stepped wedge, cluster randomized, and then there's some innovative stuff around if you want to do adaptive trials. We just did a really painful to write paper about adaptation and sort of like conceptualizing adaptive implementation strategies versus adaptive trial design. It really gets into the weeds. We can talk about it, but it's basically trying to say, if someone fails the first strategy and you re-randomize them, what do you do next? So a SMART can help you figure out some of the early phases of that question. And then who's heard of hybrid trials? Okay, almost everyone. So this is an important part of implementations, sort of testing that we talk a lot about in our consultations. Hybrid trials are testing at the same time effectiveness and implementation. The hybrid ones are mostly testing effectiveness, but you're asking a secondary implementation question. So I think all efficacy and effectiveness trials should be hybrid ones where you do, after you test whether something works, then you try to figure out what like what sort of got in the way of it working, what are the anticipated barriers and facilitators of using it in the real world. So talking to people in the settings where you're testing and trying to figure out what strategies would be needed. So I think every sort of clinical trial is an opportunity to understand implementation in a way as a second or third aim that can make it into a hybrid type 1. Hybrid type 2s are equally testing effectiveness and implementation strategies. So all of these are with generally evidence-based practices. Like you have a good sense that they're pretty evidence-based, minus the one, which a lot of implementation scientists don't even want to review hybrid type 1s. They don't consider it true implementation science in the study section and stuff, because it's really more of a clinical trial or an effectiveness trial. And then hybrid type 3s are really focused on, I do these comparing the effectiveness of different implementation strategies, testing composite implementation strategies with a secondary effectiveness question. So just making sure that the patients are still doing better with whatever your cancer screening or whatever your EVP is. Okay, almost done. Okay, the reason that we evaluate implementation is because, and I would say this is why I think every study probably should be a hybrid one, is because you can have an effective intervention, but it's not adopted, or it's implemented with poor fidelity, or it's not sustained, and then you end up saying that the intervention stinks, but in reality, it's an implementation problem. And so I think this is why I try to get all of the sort of effectiveness and efficacy researchers that I work with to think about this, because I'm like, you have to at least look at your implementation outcomes. And so this is the Proctor taxonomy of them, divides into implementation outcomes, things like fidelity, feasibility, acceptability, service outcomes, efficiency, patient-centeredness, client outcomes, satisfaction, function, and symptoms. Client outcomes are what we generally think about. And this is the CFER outcomes addendum. People have a lot of confusion about this too. So the point of this is not for CFER to be a framework that rules them all, but it's just to say that there were a few points of confusion when people were applying CFER that they tried to clarify with this outcomes addendum. So the first thing is to think about the outcome of the innovation. So what is the innovation or EVP doing, which is innovation outcomes separately from your implementation outcomes, which sounds easy, but it's not always that easy to disaggregate, especially when people are not clear about what's what. And then the other thing is that depending on the timing of you applying CFER, you may be thinking about anticipated outcomes, or you may be thinking of retrospectively about actual outcomes. So, for example, if you're planning a study and you want to understand barriers and facilitators of EVP-X, and EVP-X has not been implemented yet, then you're asking people to think about what do you think would be the barriers and facilitators? And that's really different than when you're coming into a hybrid type 1 and they've already done EVP-X and you're asking them to think back about actual barriers and facilitators. So it's really important to be clear about your stage of implementation and your implementation outcomes. The implementation outcomes that you focus on may depend on the stage of implementation too. Okay, and this is REAIM. This is the updated REAIM, but this REAIM focuses on reach, effectiveness, adoption, implementation, and maintenance of the EVP. So there's a lot of confusion among reviewers as well as scientists about this. So this was intended to mean reach of your evidence-based practice. How many people get the thing? Effectiveness, does the thing work? Adoption, is the thing being used by the clinic? Implementation, how well are they using the thing? What's getting in the way of using the thing? Maintenance, is the clinic offering the thing? Are all these outcomes maintained, after the study is over, or, In terms of sustainment, this is an important domain of implementation that is often understudied and there's just a couple of references in here for you to look at, but important to measure, important to think about. We have worksheets that we work through with our sites to make sure that they are set up for sustainability. There are known things that are sort of barriers and facilitators specifically of sustainability. for sustainment. This is a very nice, this is work by J.D. Smith, who was in my implementation research class or whatever. So he's a really great guy, and he developed this logic model of implementation research. And it basically is just stick in the box. What is your intervention? What is your implementation strategy? What are your outcomes, methods, and then determinants. So, but you could substitute other determinants, but it's just a nice way, like when you go into a consult, to kind of organize the thoughts for the people in the consult. So, in summary, implementation science offers a suite of methods and frameworks to support T3-4 work. There are simple steps you can consider when developing and conducting this work. And so we'll go through an example in the next part of the workshop. So thank you, guys.
Thank you, Shari, for your talk. The way that this is set up is I'm going to have it now a Q&A here about the lecture, and then we're going to be going through some interactive activities for the rest of the hour with the document that you have. We'll try to make this also accessible to the people in Zoom, so stay with us. Our camera is not working here, so we're going to be trying to make the best of this possible. I have a few questions, and please, bring your questions. That's the reason we have her here. Also for the people in Zoom, please send your questions via the chat function, and we're going to be reading them and try to answer them here live. I have a few questions where our audience think about your own questions. First, I want to just say I love your examples from the VA. This week, Jen and I were just talking about how in the next version of CTSI we can include our VA 11. So I think you gave us a lot of ideas, and hopefully implementation science can be the good connector between bringing CTSI and the VA, and maybe I will be just contacting you a lot next year, which I think is really good. There's tons of opportunity for working with the VA in this particular space. I have a question. As you were developing this new CIFR, in the prior CIFR, and I was part of that effort, we developed some measures with Michelle Kaler, Maria Fernandez, and all that. So with new contracts and new readjustment of those domains, are new efforts to redevelop or retest new measure for those contracts? Because one of the main issues in the field is that people are just saying, oh, this looks so beautiful, but how we use this construct in real world, because CIFR does not provide clear guidance about how to measure things.
Yes, great question. So that's where I come in. With old CIFR, they developed the PCAT, pragmatic CIFR assessment tool, which has about 12 constructs and a Likert scale. And those were the constructs that the CIFR people found through doing a bajillion interviews and assessments to be sort of the most relevant in most implementation projects, and put into a measure that has been used a fair amount. We have used what we call a CIFR survey, and so part of that grant that I was talking about, which is like a VA merit, it's an R1 equivalent in the VA, is to validate a CIFR survey. So we've been fielding a CIFR survey. We're going to do
with all contracts, all domains?
Yeah.
Okay, wow.
In new CIFR,
okay.
Updated CIFR. Yeah, so it's updated CIFR. We have gotten about 200 surveys back from providers, and then we're going to do follow-up interviews with them, blinded person to the, we'll do the interviews. So we're starting that now. I definitely would be excited to do that outside the VA with some, if you guys have non-VA people that you'd like to see if it works with. But yeah, we're hoping to validate that. We have like a really amazing psychometricians and machine learning people, some like the original CIFR team, and I think it's been really fun so far. It's also, been painful in certain ways that all psychometrics are.
Yeah, no, I think I would imagine it's a very large survey.
It actually doesn't take that long, you'd be surprised. And we think that we'll be able to collapse some of the Likert scale. So instead of going from -2 to +2, we may just be able to do a 3-point scale, but we'll get there more to come. The inner setting survey that you helped to develop, That can easily be mapped. So there's one of the appendices from the CBER paper just basically maps one-to-one the construct, so it can just get mapped and reused. So we tell people, like, if you're already using, it's all the same thing, it's just some clarifications with the update. Doesn't need to be, you don't need to redo everything, don't redo anything.
Similar as you have a new safer, you mentioned that you're reviewing also the ERIC strategies.
Yes.
Are you planning to submit like a new ERIC 2.0 or something in the future?
Yeah, so we're having our first meeting is actually next week with the ERIC developer team. We already had them go through, so we've worked with clinicians to sort of create clarity around each of the ERIC items. So they're really items, you know, they're or strategies. So we already had done cognitive interviews and ratings with clinicians in the field, so people who are not implementation scientists and how they interpret the items. And then we had the ERIC team go back through and, you know, 10 years later, let's think about this again. And so now we're gonna do some structured work around sort of, I would say tweaking it rather than ERIC 2.0. It'll just be some tweaks and clarifications.
Okay. Any question from the chat or any question from the room?
I do have a question in the chat.
Okay.
LJ wrote great talk, and then also one question that comes a lot in her research is at what point does something become officially evidence-based?
When you say so in your grant. No, I think, look, I think, you know, I run into this. So, you know, as a liver doc, we've been doing liver cancer screening for people with cirrhosis. It's part of our guidelines. It's what we do. We've all seen it be really important for our patients, and we've all seen people who don't get you know, HCC surveillance, and then they die and they're outside of transplant criteria. I mean, so anyway, everyone does it. We know that it's good. There has not been a high quality randomized trial of screening versus no screening that shows improved mortality. So this evidence synthesis just came out from the VA saying, this is not based on rigorous evidence. Okay, it's true, but it's still, you know, there are some things that will never meet whatever, you know, the Cochrane standard for evidence-based practice. I think it's just the preponderance of evidence is there. You can also, a lot of people say evidence-informed practices. I mean, I think that most of medicine does not meet rigorous evidence-based practice criteria. So I think as long as you make a good argument in your background paragraph of your grant, you're okay.
I actually have a piggyback on that, which is if you are one of the people who is trying to create that evidence in a more traditional framework, and then want to move into implementing or de-implementing that practice based on the evidence that you have helped create, is that useful, or is it better to let sort of other people do the work around the implementation, de-implementation piece, because whether you look biased because you were one of the people who helped to create the initial information, or because you're the expert, should you then move into that next step?
I think it really depends, but I think that there is no way that so like if you're talking about a complex behavioral intervention or that you developed, I feel like you are uniquely positioned to inform implementation. You may not be the person to you know, you may just based on whatever your training or your background that you bring into it, you may want to partner with someone who thinks, because I find that clinical trialists and implementation trialists sort of think slightly differently. And so and I always believe in diverse teams, diversity of thought, experience, opinion. So I don't think you would go wrong by working with an implementation scientist. My mom actually is an intervention developer. She developed trauma-focused CBT. And so that's getting implemented all over the world. And so we talk about this all the time. She's like, I implement that. I'm like, you're the intervention developer. So when other people are testing what the important, you know, key components or the adaptable components are and stuff, she has really good opinions to bring to that. But I think, like, you know, she works with an expert in implementing interventions in Zambia to implement in Zambia. Like, she would not be the person to try to adapt it for that cultural context or to implement it there. So I think it just depends. We debate this a lot. Implementation scientists would say, be involved, but not the only person.
I think there's one way in the way that we frame EBI in a grant application, but also, when you look at national guidelines, when you look at Cochrane, when you look at the NCI evidence-based cancer control program, when you look at the community guide, you're gonna be seeing these different rankings. So I don't think there's like a one size fits all.
Mhm.
I think it's how we just show that. I would say that I was part of the team who developed the evidence for the announcement approach, and Jennifer Mott was part of that team as well. So we did a large trial in North Carolina, and then, we found that the announcement approach was effective, but it took for another team in Colorado to do a replication project larger than ours, just to find the same evidence. And then we went to CDC and to NCI and say, hey, we did it in North Carolina with 30 clinics, and then Colorado did it with more clinics and more diverse population. So this should be part of the EDCCP of NCI. And that was the way that we were able just to say, this is evidence-based, and with the tag from NCI. So I think in our case was only 2 trials, but I know from other type of health conditions may take more trials, So I don't think there's a clear answer there.
It's just how you make the pitch.
Other question here.
I was just gonna add on to that, in thinking about how we classify like evidence-based. So I worked with County Health Rankings and Roadmaps, and their What Works for Health database, they have a section that is considered expert opinion.
Yeah.
It is very much for those interventions that you can't really ethically do a clinical trial on. So even things like Social Security, we are pretty sure that giving older citizens a check every month post-retirement is a good and helpful thing. There's no actual clinical trial that randomizes people and gives some people a check and some people not, so you can't, there's no evidence other than we're pretty sure it works based on lots of other stuff. So that might be an interesting place to go look, just because they do include other things than outside of the very specific things that include trials.
Any other question or comment from the Zoom or in person?
We have another one from the Zoom
Okay.
that says, also from LJ, it says, so in the context of having a trial ongoing, how do you start writing the D&I grant? If the trial data is not yet done? Then she said the grant's gonna show up, it gets confusing and fuzzy.
Yeah, I have not tried to do that. I think it really depends on the EBI and if you can make a generalizable argument. And then again, is it actually ready for implementation? It sounds maybe not, but I know people have to survive in academia. So what's the next step? Is the next step a hybrid type trial where you propose, I think the next step is generally a hybrid type trial or a secondary implementation trial to collect implementation outcomes from your efficacy trial. But it depends more. I would have to talk to you about details to be able to answer how you would pitch your next one.
For LJ, not a problem, because you're gonna be meeting with Shari later, so that's good. Any other question here? I see one there.
I was just reflecting on the intersection of this work, implementation science, and community engagement. And so across the cycle of community engagement within research studies, how do you find community partnerships to really inform the implementation of this work? And is that something that we want? Is the impetus to engage community in these discussions early on so that the implementation can be more effective?
Oh, absolutely. Yeah. I think it's interesting because our CTSI had an engagement core before it had an implementation core. And I was sort of like, these guys are already doing like half of what we do, I was like, I think, and a lot of the people that I work with come from sort of the CBPR land. So yes, I think implementation always goes better when it's engaged and partnered. So all of the work that I do, we have patients, providers, and policymakers on our team. So I think you can't do good implementation without good engagement. But measuring that is an important, I think, implementation outcome too. So, and I think for the community engagement core, the only way that what we did was just say, let's think about not just community members and patients and families, but also healthcare delivery partners, providers, nurses, schedulers, people like that engaged in that whole journey mapping. So, yeah, do you agree?
Absolutely, yeah,
Yeah.
I see a lot of synergy between the two, but just trying to figure out how we can better work together.
I think there's a lot of space to improve, like to learn from each other for sure, yeah.
No question from the chat? Okay, I have one last question before going to the activity. I think this tension about, you mentioned, when we test strategies, you mentioned, or group of strategies, how many strategies is the ideal number to test in an intervention? Because in a study, because the issue is that the more strategies you put as a bundle, the more difficult it is to better understand which of the strategies is best for that particular EDI or context. In your experience, how many you put together, or tell more about that? I always think that maybe 2 is the maximum number for me.
It depends what
it depends, yeah.
Yeah, because facilitation has 10 sub-strategies, so that's really 10 strategies. So, okay, so this is not worked out at all. What we have tried to do is use configurational comparative methods, which are basically these Boolean algebra-based ways of thinking about strategies. So you, instead of thinking about the independent effects of individual strategies on an implementation outcome, you think about the combinations, almost like how do you get through this circuit? What is your path to success? And so we've done that, and we found sort of somewhere between 1 and 4 strategy combinations could explain a lot of Hep C, for example, over our 5-year implementation measurement period. But when we prescribe strategies, so that's sort of the size of the bundle, but there's a lot of unmeasured components as well. Like there's the team part that's sort of inherent in any implementation effort. There's the leadership engagement that's inherent in any implementation effort. So I think there's an acknowledgement in the field that you need a bundle to be successful. The ideal number and the ideal composition of that bundle is unknown, and I'm interested in it. But I think it's going to be more than 2, depending on which strategies they are. And I think it's also going to depend on what they target and what the issue is. But I think just figuring out sort of so what we found in that systematic review was that all of these trials were using, I think it was an average of they were testing an average of 16 strategies in their bundles. Like when we disaggregated their bundles, they weren't calling them bundles. They weren't using the Eric taxonomy to divide them, but we basically did a lot of work to try to categorize all the different strategies that they were using. So there are some trials of like audit and feedback or facilitation. Those are, like I said, multi-component strategies, but there's really not evidence. There's not enough evidence.
One last question, you know, other one. We were chatting yesterday about the overuse or abuse of implementation science in grant applications. And that's one thing that I'm seeing as a reviewer in many study sections, that people want to measure acceptability, and suddenly people spend half-page explaining theory models of measuring acceptability, where many reviewers, like you were saying, many reviewers in a section will not review a hybrid type 1 for multiple reasons, right? What I'm seeing sometimes is that many faculty come with good questions, but they don't translate correctly to implementation science at that particular stage. How you manage that to help clinicians and help researchers be aware of implementation science, but not overpromise in their grant applications, because when you send that to a study section, you're in trouble.
Yeah.
You will score very bad, because reviewers like me will say, this is not implementation science study, you're just measuring feasibility.
Right.
That doesn't make feasibility is a handful of questions or maybe a few interviews, that's not science. How you help researchers to accommodate that in their grant applications?
Yeah, I think it depends. I'm willing to meet with anyone because I think we've probably done too good a job of promoting the importance of implementation science, because we do get a lot of consults where we're like, you actually don't need me on your grant, but you can take this paragraph and write it as future directions. Yeah, so I'm always happy to meet with anyone, and to me, it's like a sign that people are interested. And so I think it's just sort of how do we best use the resources of the university to support that people who really do need implementation methods and make sure that clinical trialists who are brilliant clinical trialists don't get screwed up by trying to add in something they're not ready for. But just as the next step.
That's one thing that we have been running here on recently, and I think it's what you're saying, helping people just to understand where you are in this implementation science continuum. So again, this is really good to start collecting some information here, but my advice always, don't focus too much on implementation science question, because this is not. And then when you do that, you're trying to bring, the study section will bring someone like me just to review your grant, and that reviewer will score you really, really bad, because this is not implementation science.
I mean, the other, so our PI of our CTSI is like obsessed with this like path to impact, path to implementation. So he wants every investigator applying for a pilot to fill out, we made this like rubric for like considering. So I just tell people like, that's nice for your impact statement or your future directions. Like, this is something even basic scientists should be thinking about. What is the ultimate clinical impact? How would this move to be implemented in the real world? And that can go there. Like, it's a good exercise to think about, but not necessarily that you need on your grant.
How about the opposite? When you're like, I want to do this little thing, but then I accidentally use a word that the implementation scientist in the room is like, that word means these things to me. And I'm like, but I just use that word in this like totally other context. Like, how do you get around that when you're like, what I'm not doing implementation, like I understand that this isn't what I'm doing, but then you use a word that other people interpret as being in these frameworks.
I mean, I just think this is a problem with science, is that people are crazy, but I guess I would just say, I mean, just like common sense, like defining your terms and being careful about them. I actually find the clinical trialists to be more challenging. Like I did that OBSSR training, it's like clinical trial training, and I found them to be more stringent about terminology than the implementation scientists tend to be more fun-loving and a little more forgiving maybe, but maybe it's evolving and so it's not.
Good. We're now moving to the second portion of the workshop, and Chelsea's going to be showing on the screen for those joining via Zoom the 7-step worksheet that Shari was sharing in the last hour. So with those here in the room, we're going to be doing a quick exercise just right here. The more you can participate, the better. Let me, Chelsea, can you just go? Perfect. Teddy, how do you want to do this? You want to take one example here from the room?
Yeah, and I might pick on people with laptops open. No, I'm just kidding, I'm totally kidding. All right, does anyone have a study that they're thinking about and they want to work through with? Like, this is like a great opportunity because of the brain trust in the room, and nobody will steal your idea. Does anyone want that?
Or maybe if there's no rooms right here, maybe you can use one of your own example from liver cancer or maybe something like that.
Okay, all right, okay, how about,
let's give some people a moment here.
Yeah,
there's some people doing some food as medicine here. That can be a good example here.
I have a project that I think should have a framework and a process.
Okay, sweet. What's your, so the first thing that we're gonna do is step 1, and this is something that I think everyone in the room is gonna be good at, which is defining their problem. So what is the overarching problem that your research focuses on? Like diabetes or cancer?
Improving access to healthy foods in communities.
Okay.
Shari, can you repeat that?
Healthy food access in communities. Okay, I'm gonna stand behind this. Okay. Healthy foods.
Oh, we're typing that in, we're typing that.
Oh, okay. All right. So do you have, is there an intervention? What would you describe as the evidence-based practice? And anyone can jump in. So I guess you would say you're working on nutrition, health and well-being of communities, and the evidence-based practice is?
So I get caught up here right away. Because the evidence part is good food makes you healthier. Whatever food that might be. So is that the evidence-based thing? Yeah, but the project, there is specific projects providing incentives or vouchers for people to buy more fruits and vegetables. That's a intervention that's being tested as a way to help people.
Yeah, we can say here maybe that there's an investment of something called Farmers Market Nutrition Program vouchers, or there's many other.
There are many
vouchers that are used as an EVP, I would say, because they're heavily funded by WIC and the state for supporting different type of populations to get access to healthy food.
So it's interesting because I guess, you know, what is the gap that you're trying to address? You're trying to address this gap that people aren't getting enough food. And we're not totally sure that the vouchers could also be considered a strategy, you know, so I think you can think about it, but let's say for now, providing vouchers is the evidence-based practice. Is there a gap where people are not getting vouchers that are supposed to get vouchers?
Yeah.
Okay, so let's think, so what would you like to improve? What is your goal? So we'll say vouchers are your evidence-based practice, and what is the outcome that needs to change? Like, what would mean success for your project?
Well, if you start with the needs assessment part, you have to find out what people know about it. Maybe they don't know about it. Maybe there aren't places where they can use the vouchers. Maybe they're.
Oh yeah, you're already on step 2. You're totally ahead of me.
Okay.
Maybe
But that's
the
good.
goal here is to increase the use. There are two problems here, and I think there is one about expanding the access to these vouchers, and the second one could be among those with the vouchers, how we increase the use, because with those people with the vouchers or any other type of these things, utilization is very low. I think, Susan, you can put a number there, like.
Distribution and redemption.
Yeah, distribution and redemption, yeah.
Okay, so then I would say your implementation outcomes are, you know, maybe reach of the vouchers, so distribution, and then use, I guess, is sort of like implementation or adoption of the vouchers. So, and this is why it's really important to think about your implementation outcomes early, is because when you think about your determinants and you're conceptualizing what's getting in the way, and you brought up a lot of really good determinants, you need to think about there's probably a different set of determinants or things that are getting in the way of somebody actually accessing the voucher versus like getting a hold of a voucher versus using a voucher. Like those are probably different problems that have different root causes that require different strategies to address them.
Are they separate evidence-based practices?
It's hard to think of them that way, right? Those are behavior change objectives. Okay, so I think using the voucher is sort of, you're targeting the person who got the voucher. I think if it's, you know, I think the simplest way to address it is to think about it, like if you're writing a grant about it, if I were writing it, I would think about it as reach of vouchers. So getting people access to the vouchers and motivating them to use them. But I would think about the use of them as almost like a secondary behavioral outcome, and think about the system level stuff that you can toggle to try to get the access up. So I would think you could address both in the same project, but just for ease of presenting it, I think that, you know, working with clients and patients is sort of a downstream thing to get them to use it. And so I think it can be part of the same grant, but maybe for now we just focus on access to the voucher as a first, and then we go through it and then we can think about the other part later.
We have to have one before the other, I guess, anyway.
Yeah, it's necessary to get them to people, and then maybe part of that effort is thinking ahead about, we need to do something when we distribute them to get them used. Like we want to give them to people and motivate them to use them at the same time, something like that. So, does anyone have any thoughts about that? I don't want to be the only one talking. Yeah.
I was just thinking, as you are giving out the vouchers, you can ask for, you know, what would help them use it, like maybe gather some of the events where you're disseminating vouchers, like maybe you give out the vouchers and then the farmer's market is right there and they can go and use their vouchers right direct next to the place where they receive the vouchers. So maybe just garnering that feedback from the recipients of the vouchers to learn how to be facilitators to it.
Yeah, and I think you're right that there needs to be a needs assessment, and so you brought up, I think that's right, is like what is getting in the way and asking the people of what's getting in the way. So if you were talking to voucher users, like you would talk to the people about how do I get you to use this? How do I put this in a place where it's easy for you to use? How do I design the innovation to be something that you want to use? So that's sort of like designing the EBP or the innovation for an end user, which I sort of think about, that's sort of what you're doing when you're talking to patients or clients versus when you go and you talk to whoever's doing the distribution, you're talking about the distribution side of it, but informed by what patients want. So I generally tell investigators, talk to the patients first, figure out what they want in this innovation, what's gonna make them wanna use it, all that stuff, how it needs to be delivered. Then talk about clinicians, and then you have that information when you're talking to clinicians about what gets in the way of delivering in a patient-centered way. So part of the innovation or the evidence-based practice should be patient-centered delivery. You know what I mean? It's sort of circular. Okay, but let's talk about the barriers because you started talking about them. Does anyone want to spitball some out and we can put them into domains? I heard patient education. Yeah?
Yeah, that goes along the lines of patient education is because you may have voucher and access to farmers market, they don't necessarily know how to use the product from use.
Right,
So
so
to be actually, right, once they've obtained it. they
Right.
know what to do.
What do you do with the pepper?
Right.
How do you make, how do you cook the pepper?
right, yeah, so we're talking, we're talking about which domain would we put that in? Yeah, so it's a characteristic of the patient or the end user. And does that pertain to their opportunity or their capability around using vouchers? So maybe patients don't have the opportunity to get the vouchers, they don't have the capability to apply them well, something in that domain. And the perception of people giving out. So if the thing you want to change is people giving out vouchers, like if that's the first behavior that you want to change, the way that I would frame that is sort of providers or the person who's the distributors do not believe that patients have the capability. You know, that's what gets in the way of the access issue is that the providers don't believe that patients can use it, if that makes sense, for the access issue. If the access issue, you should be talking about people who can improve the access.
We're in the community space as opposed to a clinical space, which I get caught up on a lot, and you're doing it too, you're talking about being a provider in a clinic.
Yeah.
But we're in the community, so it's like
Who's
these
the
people,
deliverer?
Yeah, just out in the world.
So let's define our domains before we start talking about the problems with them. So your innovation is your voucher. Who are your individuals?
Older adults and WIC eligible. Low income.
Okay. Low income older adults, and then who's doing the delivery?
Clinics, no, WIC, right?
And I was just thinking, the public housing authorities, the food banks, locations where people can go and have access to the voucher and help them, educate them and get them to the voucher.
And who is giving them to the food bank or where, like how does it come down? Where does the funding stream come from?
It's through the state, right?
Okay, so state funders. Then there's people in all these agencies. Should we call them agency workers? Or there's staff in those agencies?
Yes.
Okay. All right. And where is the gap?
There's also an intermediary, you got your state funders and you got your umbrella organizations that are doing all the clinical sites too, so there's layers in that.
Okay, so I think for this individual's domain and defining, And I think we kind of jumped ahead, and this is exactly why we wanted to find these people. So we're talking about the right people when we're asking about what the barriers are. So this is good. Okay, so there's sort of like your policy level, state government people. There's the agencies, there's the people in the agencies, and then there's the staff members who are actually doing the distribution. So this is where I would say, where is the big, do we have a diagnosis of where in that cascade of behaviors the problem is?
I don't.
Okay, so that might be part of something to kind of work out is like, so for example, we're doing this colorectal cancer screening thing, and what we found is everyone's getting mailed FIT tests. But when the FIT or the stool test is positive, you have to come in for a colonoscopy. Otherwise, you just found that there's a problem and you're not doing anything about it. So that was where we were falling off. So like say 80% of veterans are doing some sort of colorectal cancer screening, but only 40%, and with a big range across sites, 30 to 70% of patients are coming in for their colonoscopy. And so that's where that implementation gap is, and that's where we want to target a different behavior, which is what strategy do we need to help those sites that are low performing get their patients in? Because almost always it's a structural issue, and it's not like, there's nothing, I think we do a lot of patient blaming in medicine. I know this is a community project, but
I think the same can apply here because we know that among those sites, the senior centers and the weak locations, there's a lot of variation. We are working right now in some counties with the lowest redemption rates, and I think that is a problem that we're trying to solve. There are some counties, there's some locations in the state with almost 70-75% of redemption rate, but the ones that we're working are in the low 30s or even in the high 20s. So the thing is that, very similar to what you're saying, how you bump that number to increase the.
So, okay, so those low performing sites, are they agencies?
Yeah.
Okay, so that's kind of your inner setting then, is each agency is an inner setting, and then the outer setting is the bigger system, the government, WIC as an institution, right?
The inner setting could be, you mentioned before, those things that are static in the community and those that you can modify. In this scenario, the outer setting can be where you redeem those vouchers in that outer setting, right? Because the issue is that farmers market or groceries or other locations where vouchers can be redeemed. And that is something that is modifiable at the community by making those locations more accessible.
Okay, so the redemption centers?
Yeah, if you want to define them as redemption centers, where people can redeem for fresh produce,
Where they can use the voucher. So you get a coupon from your senior center to go get carrots. You have to bring your coupon somewhere to get the carrots. And then which places will accept your coupon?
Well, and the somewhere changes, right? I mean, I think about like, okay, so it's Thursday afternoon right down the street, or it's Saturday morning a mile in the other direction, or it's only certain times and places, and that's really difficult.
That's the outer
to navigate.
Well, and then you might have transportation barriers too,
Right.
so maybe that's.
The interesting thing in this project is that the inner setting is the one who gives you the thing, but you have to go to the outer setting to redeem them, which is the thing that makes this more complex.
But I thought we were focusing on the problem of
I agree.
distribution and not the redemption.
Yeah,
I think we
true.
need to, I think
It's true.
let's focus on increasing access to the vouchers. So the distribution people are the inner settings that we want. We want more people to have the voucher at the end of this project. And use it, but we're gonna talk
So
about
the
that.
question, as people are talking though, this is what always catches me. There are so many problems.
Okay, don't worry about that.
And so do you say, okay, I'm very put it in a box.
Okay.
Which box do these things go in? And do you say, okay, I need a different box for that set of problems, and I'm gonna talk about that later. I think that's what you're saying.
I think you can do this for the
For the one
distribution
thing.
and then do this
Yeah.
for the redemption.
And take a new
And
column,
think about, because you
yes.
need different stakeholders in the room
Yes.
too,
But
right?
but yeah, and I think I just keep going back to who needs to do what? Like, for you to say that you're gonna measure and you're gonna say we've successfully implemented. And that is, for this first part, which sounds like maybe you don't think it's actually a problem, is like, these distribution centers will distribute these vouchers to people who need them, and we will measure, and it will go from 20% of people getting vouchers who need them to 80% at the end.
No, that's also a problem.
Okay.
So these counties have
I
the
think they're
lowest
both,
distribution and the lowest redemption, even for the number they give out, so.
Okay.
Well, that's why you have to do that study of the whole process, like
Right.
each, how upstream do you need to go to start a process?
But is that right, that you could do this
Yeah.
for the distribution, and then you could
Absolutely.
reapply this for the redemption?
Redemption is harder because we're talking about more of like maybe client-facing strategies.
Yeah.
I mean, I don't wanna say that it's harder, but
It's also systems though, because if you don't have those distribution sites, which is
Right.
what we've run into, that's
Yeah.
not client facing, that's actually systems.
yeah,
So.
I agree. So I think
It's
you.
both, I think.
This is, yeah, so I think that you wanna, what I would do is use the first project to do the distribution, and then like, I don't know your name back there, but you had said, then use that as the opportunity to figure out, well, why is there a gap? So now we've gotten these out to people, why are they not using them?
Yes.
Yeah,
I'm hesitating, trying to be mindful of not like putting the responsibility on a client. I spent 10 years in a WIC clinic
sure,
doing outreach. And so exactly this, there's really a psychological behavioral component here with your client in a perception of what is the value of this farmer's market voucher. For, say it's a value of $30 a month. Is it worth that $30 of what barriers they have to overcome to get them? The transportation, the childcare, you name all the social
Exactly.
determinants of health. So we have to, you gotta qualify those psychosocial barriers to the value of this voucher. Is it worth getting to
Well,
even get to that next step?
and this is why I think with like public health people, I'm always like, well, back it up a step, because is this really the right solution? Are these vouchers, are there so many barriers to
Yeah.
these vouchers, are they not of value? I mean, I think that's the exact fundamental question. So we're sort of starting at the point where we assume that the vouchers are the evidence-based practice, there's something that they're designed, they're known to or are designed to help the clients in some way, and we have them and we're, we just want people to use them more, and we think that'll solve the public health problem.
At the distribution level, though, if there is a place where they have the ability to distribute, so capability, opportunity, motivation, they have the capability to distribute them, but nobody picks them up. To your point, nobody wants them. They're ready, they have their system in place, but nobody wants them. Then that means you need to talk to the people.
Right, that's a problem with your innovation.
But it's still the distribution question, because I'm capable of distributing them, but nobody will come and get them, therefore it's a distribution problem, right?
It's a demand side problem.
Not the same question. So where do you put those people? I do think those people belong in the individual box.
Yeah,
Cause it's distribution, if I'm there handing out money. and
yeah,
nobody wants it.
so and is that because clients are unaware, they don't have knowledge, they don't, we'll get to that, but
Right, they're not unaware.
It's
so
not
we need to figure
unaware,
out-
it's a perception, is this really
Motivation.
worth it for me?
Yeah.
Is it worth the $30? And then, then there's so many, there's so many problems. There's so many layers to this. Then there's also, our perception of food. I always call it food amnesia, like the perception of is there a value in accessing produce when I can just make box macaroni and cheese for 20 cents or whatever. So it's also, there is a whole behavioral component to that.
yeah. Were you gonna say something?
This is maybe a little off of the topic thing. I was also curious about the values and beliefs in the outer setting, and do people see it as as a handout and maybe feel embarrassed about taking out a food voucher.
Yeah, exactly, and we are totally still getting ahead of ourselves, but we defined inner setting as the agency, outer setting is everything outside of the distribution agency. And I agree, like stigma, perceptions, sort of like the culture, the general culture, the local environment, are gonna be important in the outer setting.
I have would that be part of that needs assessment that happens in step one? Like, I'm trying to think, like what she was saying of the perceptions of people, like.
Sure.
Of the thing,
Yeah,
right, the perceptions of the thing.
right,
Yeah,
right, of the
exactly.
thing, that,
Where does that go in this?
So that would go, you can code that, so if it's perceptions of people who are in a position of power for implementation, which I think, yes, then it goes under perceptions of the innovation. So that would go under innovation.
Step two, okay.
Innovation, the innovation, like, we're just defining the domains, and then, yeah, like perceptions about the innovation would go in one. So perceptions about like the evidence base, the relative priority or relative advantage of the relative advantage of getting the voucher versus not getting the voucher, getting some other kind of assistance, or cooking something else, you know, that all sort of fits. This is I'm gonna tell you guys, this is a really hard example.
I think that one, you're thinking that was gonna be a little bit simpler, but I think.
Oh, no, I did not. I was like, can we talk about like,
our
medications for diabetes?
Our team has been working hard for the past 5 years, 6 years, trying to solve this issue, so.
I think, I think you kind of have to disaggregate sort of, like the client needs and resources, sort of thinking about that. I actually think about it sort of as almost an old secret language as an outer setting issue, because the person's behavior. So anyway, I guess what I would say is simplify it down to a behavior you want to change. You want the distribution centers to hand out more vouchers to people when the people come. So we probably, when we get to solutions, which is not until step 4, we're gonna think about, we need to do something client facing.
I think
Yeah, I like that, I like separating the pieces though, I mean, I think that's what happens, it all gets
Right.
spaghetti rolled together and you can't pull out the pieces of spaghetti anymore, and this is helpful.
Just for other people here, just the connection with another problem that is clinically oriented, and you have been talking about CRC. I think the same would be, we need to disaggregate, for example, handling fit testing for initial screening, and then another problem would be when there is an abnormal test, how you follow with those people.
Yeah.
Right, bring it to the colonoscopy. Right. So if you wanna deliver an intervention with CRC screening tests and outcomes, you have to understand both things, because both are different problems.
Right, and you also need to define the behavior. You need to define the problem, and usually that's based on data, like where is the cliff, where's the implementation cliff, or where's the first cliff, and then the outcome that you want to change, that has to be first before you, because otherwise you just get around in circles. Okay, so the next thing that we would do, so we sort of brainstormed about barriers. We can, sometimes I just tell people, circle a few that you think might be important, and then let's, in the diagram even, and then let's go to prioritizing them. So so you said, sometimes it's really overwhelming. You have so many barriers. You have patient level barriers, you have system level barriers, you have cultural barriers. So how are we gonna prioritize them? So what I would do, and I'm looking at the CVPR people, community engagement people in the room, we need to put people in a room where we can ask them, like, what's really going on here? And if we don't know where the implementation cliff is even, then we need to bring them in for the question. And some of this is iterative. So when you get people together, they're gonna refine your first step. They're gonna refine your problem. Maybe the problem isn't what you thought it was from the perspective of people who are doing the implementation. Maybe the conceptualization that you have of the different people or the different settings is wrong. So you have to be open to that, of course, and iterating step 1 and 2, but to even get to step 3 of figuring out who needs to be in the room, you kind of have to go through that thought exercise for a first time. So, so what I would do here is, we can think about sort of some examples. We don't have much time, so we won't go through this in detail, especially because it sounds like you have some community engagement expertise in the room that you can leverage later. So let's say we got all these people together and we did it in a really partnered way, and we prioritized a couple of barriers. Let's pick 3 barriers that we think would come out of that session. People would say these are the top barriers. Can we pick a couple?
Let's just say that people can't get to the clinic to get let's say they can't get
The
there.
transportation
Yeah,
part.
let's say they can't get
Okay.
there to pick up, they have to be there to pick
Okay, so it's almost like there's a policy that limits distribution in some way. It's really an outer setting barrier, right? Like transportation policy, something like that. Let's pick a couple others, because those are sometimes hard to address with agency-facing strategies.
could be the policy that they have to be picked up probably.
Right.
And that they could distribute them somewhere else, like the location of the distribution is a barrier.
Okay.
I think at the staff level, I don't know, similar to my work in vaccine communication, do you recommend the vaccine every single visit? So did you assess and give the vouchers to all eligible patients consistently?
That's what I was
That is
gonna
one
say. Do
question
you
that
have
I
a
have.
process for doing that, or is it sort of just if you think about it at
Yeah.
the front desk?
Okay. All right. So no process in place.
But processes with some really, bad implementation that happen very often. There's a process, but not all staff follow the process consistently. And that's the reason some people don't get it, but they should be getting
Or
that.
staff don't know,
Or staff
I
don't
don't
know.
know, maybe they don't.
So maybe we could say staff motivation, opportunity, something like that. Okay. We're gonna blame the staff. All right, and then let's say another priority is the sort of like a structural characteristic. So sort of in the inner setting, there's constraints around where the distribution or when the distribution. So sort of infrastructure barriers. Okay, so we have an inner setting barrier, and we have an inner setting staff barrier, like individuals in the inner setting motivation and opportunity. So let's look at some of the types of solutions that we could have. So we could be thinking about infrastructure changes, and this would all be way more built out and stuff, because you would actually go through a rigorous process of assessing all these things. So let's look at some of these strategies. So we said that there was sort of this inner setting barrier with the way that things were set up. So sort of like an infrastructure type barrier. So maybe there's an infrastructure type solution, or something like that, or a financial solution, something like that. And then when we said that clinicians had a motivation or sort of an opportunity barrier, maybe what would we pick to solve that? We may pick something, we would know that we need to do something with training, but generally something with interactive assistance may be helpful. And then it does sound like fundamentally one of the things it sounds like is tracking and sort of accountability or sort of a trouble area. So maybe something around audit and feedback and data infrastructure would be helpful. So this is just like an example, but I think if you actually, you would really think through all of these things and look to and the way that we sort of would prioritize barriers in the real world, I would have a hypothesis based on literature experience, talking to experts, and then we would, talking to experts, meeting people with lived experience, and then we would prioritize it. And then there's a lot of different ways to pick strategies to address barriers, but one of the ways can even be just go to your safer matching tool and say, here are the top barriers that we found, what are some of the strategies? Some of it's logic, what do we think would address an infrastructure problem? Oh, an infrastructure solution, so some of it can be logic and that's totally fine, or literature. And then the only thing left would be just to specify that strategy. So, okay, so we said that we wanted to train clinicians as one of the things. Who's gonna do the training? What are they gonna do training about? Where are they gonna do the training, when and why? And so you would go through and specify each of your strategies, and the why is what barriers do they address, if that makes sense.
And there's a big paper from Proctor with strategy specification with, I think, 7 or 8 steps to that.
Yeah, exactly.
I know, I was like, make a copy.
We are on. We're now done.
We're done.
Yeah.
Thank you, guys.
Yeah, this is something that, if we want to do it more in depth, it's something that may take a 3-hour workshop. But I think this is a very useful document that we have. We want to be adapted that to our consultations in the ISC moving forward. I think there's some projects that are ready for this type of work, some others that not, but we're going to try to do that. I just want to say thank you so much, Shari, for coming here. We have learned so much, and this was a very fun workshop. So I just want to run another round of applause for Shari. I just want to get my agenda here. If you want to have a double dose of her, you can do that because she's going to be giving another talk at 5 p.m., 5 to 6. It's going to be improving the care of the patient with liver disease.
Yeah, and GI, but
Yeah,
it's just basically like, how do we actually apply these methods in real life and with data?
So this was
A little more
implementation science talk. She's going to be doing another talk later tonight with a clinical focus. So I also want to say that you have copies of our annual review. So we have been doing a lot of work, and we're going to continue doing this, especially bringing more speakers to engage our faculty, trainees, and community partners to